Good afternoon, everyone, and welcome to the PQA webinar. I am Lauren Kirk, the Senior Director of Strategic Partnerships here with PQA. I'm thrilled to join you for a fireside chat and discussion of the definition of pharmacoequity, explore how pharmacoequity is operationalized, and review the latest research in this area. But before that, let's walk through a few logistics-related items for today's webinar. First off, please submit your questions during the presentation using the Q&A function and feature located at the bottom of your screen. The webinar recording and slide deck will be made available to PQA members within the week following the presentation. It'll be in the member resources section of the PQA website. And lastly, please complete the quick 1-minute survey that will appear at the conclusion of the webinar. Today's presentation is generously sponsored by Elevance Health. Elevance Health is a leading health company dedicated to improving lives and communities and making healthcare simpler. Through its affiliated companies, Elevance Health serves approximately 118 million people, including nearly 47 million within its family of health plans. Delivering health beyond healthcare, Elevance Health is expanding from being a partner in health benefits to a lifetime trusted health partner. So at this point, I'll introduce our moderator, Darrell Gray. Darrell Gray is an outspoken health equity advocate, a clinical and policy expert, and a passionate voice for the better healthcare system. As the inaugural Chief Health Equity Officer for Elevance Health, he leads the execution of a comprehensive strategy to advance health equity through a whole health approach. So Darrell, thank you for joining us, and thank you for your panel for joining us. I'll hand the virtual microphone over to you.
Thank you, Lauren, and thank you for the kind introduction and invitation. I am incredibly excited about this discussion we're going to have today. And again, I want to underscore something that Lauren said. Please engage with us in Q&A. As questions emerge, please type them in the Q&A function, and we'll address it toward the conclusion of our time together. We are going to have some fun. Next slide, please. Allow me to take a step back for a moment. And I want to ensure that I level set around a core definition, health equity. Health equity means ensuring that everyone has a fair and just opportunity to be as healthy as possible. And we know that to achieve that, we have to address barriers to health equity and addressing particularly what we think of inequities and disparities in care and certainly in outcomes. You know, I got your eyes to the right, to the left of this slide. And I think it's an important distinction when we talk about equality versus equity. In general, when we think of equality, we think of ensuring that everyone has the same resource and hoping that they achieve the same optimal health outcome. But as you can see in the picture, we give everyone the same resource. They may not achieve the same outcome. And so when we talk about health equity, we talk about a more personalized, not one size fits all approach to achieving optimal health for all. This extends beyond what some may look at as or have seen or experienced as a purely race-based definition of equity to addressing barriers as it pertains to geography, gender, sexual orientation, gender identity, disability, the list goes on. At Elevance Health, health equity is at the core of what we do, particularly around our whole health approach, addressing certainly those factors, those physical factors that can be influenced by what happens within the walls of clinics and hospitals and emergency departments. But more than that, what happens in neighborhoods and homes, those social factors, addressing behavioral health, and certainly what we're going to be digging into today is ensuring that we are meeting the pharmacy needs of those whom we serve. Next slide. I am really elated to be joined by friends and colleagues, and I'll start by introducing Dr. Bhatt. Dr. Bhatt currently serves as the Staff Vice President of Clinical Strategy and Operations for the Pharmacy Division at Elevance Health. She started her career at Ohio Northern University with her PharmD and MBA from Nova Southeastern and completed an executive management residency at the National Association of Chain Drugstores. Ami is a passionate advocate for the profession of pharmacy and helping patients get access to clinical programs that remove barriers to help patients live a healthier life. In her current role, Ami leads the ideation, innovation, and execution of pharmacy strategies to drive health outcomes. Her work currently consists of driving pharmacoequity among Elevance patient populations through the strategy team and Pharmacy Clinical Care Center. Let's virtually welcome Ami. So good to have you.
Thanks so much. I'm so excited to be part of today's panel.
Thanks. And our next panelist is Dr. Utibe Essien, a board-certified internal medicine physician, an assistant professor of medicine and health equity researcher at the University of Pittsburgh. Dr. Essien received his MD from the Albert Einstein College of Medicine and trained in internal medicine at Massachusetts General Hospital and Harvard Medical School. After residency, he remained at MGH to complete a research fellowship and receive a Master of Public Health degree from the Harvard School of Public Health. Dr. Essien's research focuses on racial disparities in the use of novel medications and technologies in the management of cardiovascular diseases. And in the past year, Dr. Essien also coined the term pharmacoequity, providing a new framework to achieving equitable access to care. Let's welcome Dr. Essien.
Thanks so much, Dr. Gray, for the introduction, and greetings from sunny Western Pennsylvania.
So look, let's throw the formalities aside. This is a fireside chat. We have a virtual fire in front of us. We're sitting around the fire. Ami, Utibe, we're going to ditch the kind of doctor titles now. We'll keep it casual, Utibe and Ami. Just imagine also you have a cup of hot cider at your right hand and maybe some marshmallows on deck on the left for roasting, and we're going to have some fun. You know, Utibe, can you just get us started? You coined the term pharmacoequity. What was the genesis of that? Can you define it? And what was the work that was happening in the context of this term being created?
Yeah, thank you again. And so, you know, this obviously is a question I've been thinking about a lot, you know, my origin story, so to speak, Marvel style. But really it goes back to my patients, and really have had the privilege over the last decade or so now, which is crazy, of practicing clinical medicine. And grew up kind of thinking that I was going to be this social justice warrior for my patients and, you know, fix some of the disparities that I was seeing training in medical school in the Bronx, New York, working in outpatient primary care clinic in East Boston in Massachusetts, and really seeing people who look like me and my siblings and parents getting very different care. But what I didn't realize was that just because they had a doctor that looked like me, just because they had, you know, other folks within their health setting that cared about these issues, that was not going to be enough. And there's still so many gaps in helping to ensure that they had equal access to potentially life-saving medications. And that's what this is all about. That's what that term pharmacoequity, which we defined as the goal of ensuring that all patients, regardless of race, ethnicity, socioeconomic status, or whatever kind of underrepresented, underserved, vulnerable lens you're coming from, has equal access to life-saving therapies they need to continue to live and lead healthy lives. And I think that is a goal that has really eluded us for decades, maybe just for centuries, some may argue. And it's my hope that in conversations like this, in working with leaders like Dr. Bhatt and yourself, that we'll be able to hopefully be able to achieve this goal.
That's amazing. And you mentioned Ami toward the end of your comments. And I'll tell you, when I joined Elevance Health a little over 13 months ago, it was truly a pleasure to find a kindred spirit in Ami. And Ami, you've been working at this in advancing pharmacoequity for a while, before we even had a term for it. How did you get engaged in this work? And why do you think it's important for other health plans or health plan leaders, other stakeholders really across our entire healthcare ecosystem to be familiar with this work, to be engaged in advancing pharmacoequity?
Yeah, no, I mean, I think it's a really great question. And I'm going to start with kind of something maybe a little bit more personal and anecdotal, and then give you a little bit of an instance that maybe many of you on this call, also this chat, have kind of run into. So my anecdotal story really starts with my father. He was working 3 jobs. He didn't have insurance. And it was the day that my mom was in the hospital, my birthday. While she was giving birth, he was out there trying to collect money to be able to give to the hospital so that they could release us, right, to go home. So instead of being with my mother while she was having labor, he was out there borrowing money from his friends and, between his 3 jobs. And so when he tells that story, right, that anecdotal story, I think, has stuck with me throughout my entire career, is, just the fact that our healthcare system is so complex, and really that access and that cost are such big barriers. And so I think I kept that with me throughout the course of my life, and got into pharmacy because I wanted to help people. I wanted to be able to take what I learned and my experiences to be able to impart that on my patients. And so fast forward, I was a grad intern, and a lot of it is about mentorship. And I had a phenomenal pharmacy manager, the type of pharmacy manager that Tuesday was his day off. And so that was the slowest day of the week. We didn't have as many patients that came in. It was because everybody knew Paul was off on Tuesdays. And so, he knew everybody by name. He always kept a couple of dollars in his pocket. And we had this one patient who came in, and I'll call her Miss Smith because they HIPAA. And Miss Smith came in, and I'd asked her, Miss Smith, we haven't seen you in a couple of months. What's going on? Like, where have you been? Everything okay? And she said, we're on a fixed income, my husband and I. And because we're on a fixed income, we can't really afford medications and food. So what my husband and I are doing is one day he takes the blood pressure pill and the next day I take it. And we just take turns taking it so that we both can be healthy. Mm. And, that was that one defining moment, and numerous stories after that. And many of you have had very similar patient experiences. And I saw Paul take money out of his pocket to pay for her prescription that day. Right. And so one, I saw servant leadership at its finest. Right. And Paul really showed that patient how much he cares for her and her health. And I also, that same point, got an opportunity to take a look into someone else's life. Right. Even if it's $1 or $2. Right. Sometimes we take for granted all the other things that a patient has going on in their life, whether it's cost or transportation or food, or even, other things, other social drivers that are happening behind the scenes. And so when you ask, why is this important? It's important because it's not just about the social aspect of it. And it's not just about the corporate aspect of it or the business aspect of it, right? It's really all of those. It's not either or, it's and, right? It's the intersection of all of those things coming together. So together, one at a time, one patient at a time, or groups of patients, or that we work together to be able to impact that patient's life. Because that day, Paul impacted Miss Smith's life, and I got to be a part of her journey and her story. And that put a little bit of it showed her how much we care as healthcare providers, but more importantly, how much we care as people.
And Utibe, you've been on the speaking circuit in regards to your work around pharmacoequity, and certainly you've engaged a range of stakeholders. Certainly at Elevance Health, we feel that health equity is everyone's business. And so regardless of whether you're an executive, you're someone who's serving in the customer service, whether you're serving in one part of our business or another, health equity is your business. And the same translates to the work that me and others are doing in regards to how we're advancing pharmacoequity. But through your lens, also through your lens as a researcher, why is it so important for all stakeholders across the healthcare ecosystem or health ecosystem to be engaged in this work?
Yeah, such a great question. Thank you, Ami, for sharing that story, because unfortunately, not everyone is going to have a Paul, right? Not everyone is going to have someone who's got a couple extra bucks to share. Like, Paul's got to eat too. Paul's got to pay for his parents' bills or his kids' bills. And so that's why we have to keep thinking about the broader milieu, right? Like, how do we make sure that from the top, from the policy level, that those folks who are making decisions that are affecting our country, affecting our state, our community, are thinking about the Mrs. Smiths in the world and how they can afford their medications, regardless of what condition they're being treated for. So we have to be thinking and targeting policymakers, which is, I think, an important lever. health systems. Mrs. Smith, and we're going to keep leaning on Mrs. Smith today, I think, but walks into a clinic or walks into the hospital, leaves not expecting that her bill is going to be what it is because of certain medications that she was prescribed or treated for. And so how is the health system working to help drop cost and make sure that people can live healthy lives by taking the medications we're prescribing for them in clinic? What's going on in the insurance side to kind of be creative around improving access to therapies by the drug makers and manufacturers? We all have to work together. There's not a one solution that's going to happen with one stakeholder. I talk about an ABC approach to pharmacoequity with access, bias, and cost. And I think a lot of the conversation is, well, doctors aren't giving patients the meds they need, or patients aren't understanding. But we need all three of those pieces to be addressed. And I think across each stakeholder group, we can all do our part to be able to achieve this goal.
I've heard you before say, this is not just about corporate responsibility, right? It goes beyond that. Can you elaborate on that?
Yeah, no, absolutely. Right. I think that sometimes we're all kind of waiting for someone else to speak up or someone else to do it because it's such a big topic. Healthcare is such a complex system. And then you add all the different stakeholders and it becomes an even bigger ecosystem, right, from a healthcare perspective. And so sometimes what happens is all of us are hoping the other company or the other people or the loudest speakers are the ones that are impacting, right? But I think it starts with all of us. It's what can we control, right? So if I'm a pharmacist in the front lines, there's a lot of things going on, right? Whether it's in the hospital or the retail setting or the independent setting, there's a ton of things going on. So if that day you make the goal of saying, I'm going to help one person today, just one, if we can make it bite-sized, right? We make it this big, huge, complex issue. And those are the things together we have to be tackling, whether it's writing letters or speaking up and being part of these chats and creating awareness and education on the topic. But there's also one step further that all of us can do, regardless of our setting, whether we're in a health plan, whether we're teaching or we're at a retail. There's lots of different, whether you're not even in healthcare, right? And maybe you're at a financial institution and there's programs and things. So I think the thing is, what can you do? What's within your control? And if everybody focuses on what's in their control, then we help more and more and more people, and it becomes this bigger, more impactful opportunity for all of us.
I love that. And you reminded me, when you were saying kind of what's within your control, reminded me, I think of some old writing. I believe it was Stephen Covey who talked about having sphere of control, sphere of influence, and sphere of concern, right? Really focusing on what you can control. And certainly that can spill into areas where you have a sphere of influence as well to move us forward. And it's not always easy, right? And to that point, Utibe, I'm wondering if you can share what you see as headwinds or barriers to us achieving pharmacoequity. You're on mute.
Excuse me, guys. 2.5 years in, you'd think we'd be ready. But I was saying these are kind of the persistent problems, right? That, I was giving a talk earlier this morning and talked about how in 1994, there was a paper published in the New England Journal of Medicine that showed that Black patients with HIV were 40% less likely to get antiretroviral therapy when those medications just came out. 1994, my dad was finishing his residency, taking care of patients in New York City with that problem. 3 decades later, we're still having the same conversations, whether it's around HIV, around cancer, drugs, around COVID. And I think that persistence of a problem suggests that there must be some deeper underlying issues that are not being addressed in our healthcare system. And so I think more broadly, culturally, not having a system that is focused squarely on and centered on achieving health equity and specifically calling out race and racism as barriers to health and healthcare is not going to be a system that actually achieves this goal. Because, in our research, we tease out all of these drivers that people suggest. are the key barriers to care. Are you sure it's not just education, or are you sure it's not employment or income, or insert issue here? And, we go back to the drawing board and try and figure out how to capture those factors in our studies. And what do you know it? We still see a difference in care. We still see patients in what I study with atrial fibrillation being 27 to 30% less likely to receive stroke preventing medications. And so we have to root out the underlying cause of racism to help actually achieve this goal. That's number one. Number two is we need a national system within our country that, again, prioritizes health and equal access to care. And we see in the VA, which is also a place where I have the opportunity to practice clinically, that some of those disparities start to decrease. They're not gone, absolutely. We look across the pond in the UK and we see disparities still exist there as well in treatment. So national health systems do not mean disparities will disappear unless we root out racism, but they help us start to get a little bit closer, help us start to actually, when we make sure care is uniform, make sure equal access is available, that will be able to do that. And so culturally and politically, I don't know if we're quite there to make those big decisions. I'd love to hear from you all, kind of stoke the fire a little bit in this fireside chat, what you think we can do to get closer to that. But I do think those are two huge headwinds that until we start to address them deeply, it'll be really hard for us to achieve this goal.
Ami, what do you think? The fire's been stoked. We got the marshmallows going in now. So
I know. I gotta warm it up here. Utibe, I think you're absolutely right? We have to look at the patient first. I think sometimes we forget that, right? Like we think about, I have a list of headwinds and barriers, right? But really, when you sum it all up, it's what is it that this specific patient needs, right? So you're talking about the larger ecosystem and what can we do from a national perspective. I think as practitioners, right, we also have to think about how do we look at the patient first. And the best way that I can kind of describe it is, right, so many times we have the opportunity, as we all know, with a lot of these disease states that you talked about, whether it's HIV or even some of our other chronic conditions, blood pressure, cholesterol, some of those, it's diabetes. It's a highly branded medication disease state, right? You have newer, fancier, shinier drugs that probably are more effective due to the research. And so that's sometimes the direction that we want to go in to prescribe because we want to make sure we're giving our patient the best chance. But sometimes, right, we know cost is a barrier, the continuing rising cost of medications and just overall, right, we think just the inflation and what's going on currently in our economy. And we think about there may be greater, shinier, fancier drugs, but how do we really look at the patient first and say that this is generic, although it's a lot older, I'd rather the patient take a medication and afford it than be prescribed something that they're never going to take. Right. And so I think looking at that patient first, peeling the onion back and truly understanding whether it's the social drivers of health questionnaires or asking the right pinpointed targeted questions to really get to the root of it. Those are some things I think we really need to address. Two other things I'd like to just kind of add into the conversation to stoke the fire. I think some of us take technology and internet for granted, right? Computers, internet. Not everybody has access. I think during COVID, that really came to light when we think about education and our children who didn't have access to turn in their homework. And they were going to, local fast food restaurants or wherever they could just to turn in their homework to gain internet access. So I think we take for granted access, whether it's access to education, we just Google it, right? Like Google's at our fingertips. So to me, access to education, that technology, and that goes back to the national, what can we do nationally and how can we speak out to make sure, and how can we work with corporations and corporate sponsors to be able to help us with some of these things that they have control of. And then the other thing I would say is, language barrier, right? We are so focused, you earlier, Utibe, talked about, you were in a community where you had someone who looked like you and had that, but maybe there are other barriers. Think about when we tell a story and if someone doesn't understand it, how frustrated they are, right? Or how frustrated we get and they get because they don't understand what we're saying. We don't understand what they're saying. Either we get louder or we get angrier. Now add a language barrier to that.
Yeah.
And are we really providing the care that we need? So a lot of different headwinds. Hopefully it has all of you guys thinking on this chat on what can you do personally to help, remove these barriers, and hopefully together we can figure this thing out.
Yeah. Darrell, do you mind if I pop in just to
please do.
kind of piggyback off of
my warm apple cider here, and
there you go.
The chocolate and graham crackers going. So please go ahead. Yeah.
We're going to get into these puns. I don't know what else needs to be around the fire, but we're leaning in. No, but I thank you, Ami, for sharing that. And I think I wanted to comment on the novel drug space, because I think that is such an interesting space to be in. And so just this week, there was another article out in the New England Journal, around access to gene therapy for sickle cell disease. And so these new therapies are coming down the pike. Like, we don't know when, we don't know how much they're going to be, but we know they're coming. We know they're going to be expensive, and we know they're going to be treating a condition that really impacts African-American population here in the States, right? And so I think that's going to be the perfect case study to try and explore pharmacoequity. I tweeted this yesterday because it's no longer going to be about, well, what about all those cool old school sickle cell disease treatments that we have? Why don't you use those? Like, this is the first time that we're going to have a therapy that really addresses the genetic malformation related. And so then what are we going to say if we see some of the disparities that we've seen across the board, right? It's not just, hey, why don't you go on warfarin medication instead of the newer blood thinners? Like, that's available. Or why don't you go on a statin instead of a PCSK9 inhibitor? It's going to be the medication that we want patients to have. And I think we're going to have a lot of lessons learned there around this issue, around like a shiny new therapy that's available. And sadly, it's always been the case that the newer medications somehow just miss out on the patients who are from underserved backgrounds. Even as they get more affordable, even as the patent transitions over, those are the groups that are missing out on. And I think we just have to keep addressing that way earlier on.
Utibe, I love that. And as you were talking, I was thinking about, well, how are our learners, our next generation healthcare providers, including pharmacists, physicians, nurses, all these, how are they staying abreast and being educated on this? I mean, I think back to my experience in medical school, right? And albeit it was many moons ago, but disparities weren't new back then, but it wasn't necessarily something that was part of our curriculum, right? So, I mean, this was still years after the Heckler report, right? Just think about Secretary of State Margaret Heckler and the Heckler report that came out in regards to demonstrating nationally that these disparities exist, right? Fast forward, we have report after report after report. And again, disparities have persisted across generations. And I even look at some recent medical school grads, and some don't get exposure to curriculum that focuses on drivers of health, right? Social drivers of health, social determinants of health, that for some people pretend poorer health outcomes. And I don't see discussion around pharmacoequity happening in schools. So can you speak to, opportunities for learners to engage around these topics that we're discussing today?
Yeah, so I think since 2020, the world around equity, justice, and race has been a completely different world. And again, my hope is that although my research focuses on racial disparities in care, that there is a broader appreciation that we're not just thinking about racial differences, that there are geographic differences, there's language and limited English proficiency differences, there's sex and gender differences in care. So although that is my research focus, just want to highlight that that's not the only. And so we've completely changed the game around our medical education. And I suspect Ami will be able to share around the pharmacy education space. I don't think we're going back, right? Like, now the US News and World Report has health equity as a part of how they rank medical schools. Like, that's something that, again, is having these institutions starting to make differences, make changes in how they really develop curricula, so that people who are like us are going out into these schools, going and give talks around the country to really ensure that our trainees are learning about these topics. So I do think that there's going to be a renewed effort and renewed focus on these topics. And more importantly, I love the fact that, again, we have Ami's expertise on this call, because for speaking to the med school side, we don't know anything about working with other colleagues. And I think that this is a huge problem in our workforce, where we're asked to be Superman, Superwoman, to be able to get into medical school and to get into residency. And then when we get into clinical practice, all of a sudden we realize that there's a huge team that we have to work with, but we've never been prepared to work with that team, to engage with that team, to learn from and learn with that team. And so my hope is that as we get more integrated and interdisciplinary in our treatment and care, we'll realize, like, there's only so much I can do around pharmacoequity for my patients. Let me refer this patient to Ami. Let me work and round with Ami so that we can get together, even though Ami may not want to round with me for 4 hours on medicine, so that we can get right for our patients. And those are just some of the thoughts I have to that comment.
Yeah, Utibe, I think you bring up a good call out, right? Is that interdisciplinary care. And I would say, I've been really impressed over the last couple of years how the pharmacy schools and the pharmacy space have really evolved to trying to figure out how can we participate in that interdisciplinary. So you see some schools that are partnering with the nursing school and the pharmacy school, or the med school and the pharmacy school. I think they've really figured out the most important part of the equation is that interdisciplinary care. Right. And, medication is kind of at the intersection when you think about it. We see the patient and, of course, there's going to be lifestyle changes and, therapy and conversations and things like that. But at the end of the day, medication plays a big role in the patient's outcome. Right. And I think the residencies that many of the pharmacy students, the creation of the residencies and then the fellowships and doing some of that, I think that's really helping create that relationship, especially in the hospital setting or the association setting, or even kind of the retail setting, is really creating that partnership and the sharing of knowledge. Because I think, to your point, right, you go to med school and you just go down that line, right? And then you go to pharmacy school and you just go down that line, or you go to dental school. But all of that, right, like when we put all of our collective knowledge together, right, when you look in someone's mouth, there's a lot that you can see. When you look into someone's eyes, right, like diabetes, there's a lot that you can catch. And if together we work, it's much easier and reduces the burden on the overall healthcare system, right, when we partner together. So I think all the different professions within healthcare are really doing a good job of trying to figure out how do we come together. I think it just takes time, like many things, right? Change is hard, but change is the inevitable. And I think, over the years, I've been very happy to see that the schools have realized that's really how you create the partnership.
I love that emphasis on partnership. And as I think about partnership, as I think about education, as I think about our health system and how it is constructed, I also think about the importance of diversity and inclusion. Where do you all think that fits into this dialogue around advancing pharmacoequity? Certainly, I'll borrow from a phrase from a former, a colleague who is kind of a peer mentor, if you will, Dr. Quinn Capers. He would always say that diversity and inclusion drive excellence and innovation. And certainly we've seen over time with papers that come out that demonstrate the importance of having a provider who connects with you. And that may be based on race or language, that may be just based on cultural sensitivity and humility. But I'm curious as to you all's thoughts, and I'll start with you, Utibe. Where does diversity and inclusion fall in this conversation?
Yeah, no, I think it's forefront. I'll start with story, give you some stats, and give you some solutions, right? So the story is that I was starting in my clinical job here at Pittsburgh and back in 2018, just finished residency and fellowship and starting a new primary care practice, and had veterans who were 55, who were 75, who were 35, who were telling me consistently that I was the first Black doctor that they had cared for. And you can be on social media and you see these stories, and almost it seems like all of us has a similar story. Darrell, I'm sure that you probably have many of those from your training and from your practice, right? And this just feels crazy to me. This is, I'm not in a city or state that perhaps does not have the same representation of African-American individuals. And to have patients who are in their 70s, decades into their life, to not have had a physician that looks like them, it speaks volumes. And these are patients who are not just telling me that story and walking away. They're getting choked up. They're getting emotional around that. And you can see how the conversation changes. And so that's the story. The stats are that 5% of physicians are Black in our country today. 5% of physicians are Hispanic in our country. About 1.5% are American Indian or Alaskan Native. And that's the country that we're living in today. That's the clinical environment that patients are coming to see us today. And that matters. That matters for a lot of patients who may not feel comfortable having a hard conversation around cost or around not understanding their medication. What is diabetes going to do for me? What is atrial fibrillation going to do? And until we address those, I do think we're going to have a hard time with achieving pharmacoequity, because as Darrell mentioned, the data are out that having a race concordant doctor or a doctor who looks like you actually makes a difference in whether you start therapy and whether you get referred to cardiac surgery or go to a colonoscopy with Dr. Gray. And so that matters in terms of some of the stats. And the solutions are simple, where the US government Supreme Court, is about to hear an affirmative action cases that started with medical schools out in California deciding that they no longer felt comfortable applying affirmative action into their state's policy. While we believe that we're in a post-racial society, those numbers that I just shared with you do not suggest that. And so for reference, the African-American population in the US is 13%, Hispanic American is 18%. And I told you some of those doctor numbers. If we want to have something that we can do today, we can hop on the phone and continue to advocate for policies like affirmative action to continue to be in place, but locally continuing to work with our neighboring schools, neighboring environments to help improve those numbers. And I'm sure Ami has some solutions that she can share with us as well.
Yeah, no, thanks. I mean, I also think it starts at a very young age, right? If I can see it, I can achieve it. And I think, it's really important for all of us to, be able to give back, whether it's to a middle school or a high school, and really talking to the students and letting them know this is a possibility. I think it's sometimes just about possibilities and what can be done. The policy is important, right? Because you can have the possibility, but you got to be able to afford the possibility, right? Whether it's with loans or scholarships. And so it's not one or the other. It's, again, that combined effort and that combined partnership to make it work, but really kind of thinking about how can we give back and how are we able to at the schools that are either near us or that are in the low income, no income areas, can we participate? Can we just ask the principal to be a part of the conversation, even if it's a 30-minute or it's an assembly? I think that's something, again, that's within our control. I try to focus on what is it that I can do, what's in my sphere of control. And that's something I can do, is give my time to the younger generation, people who look like me, right? People who look like you are the members of our society that really don't have the opportunity, the same opportunities and the chances because of where they live or because of who they are.
I love that, Ami. And I love all these gems that are being dropped by you two. I mean, PQA, do y'all hear this? PQA members, she's talking to you. There are certainly opportunities in your local sphere to get engaged at, any level of the education system. Certainly you can't go too early. So potentially, following up with a local elementary school and being visible as a pharmacist, as a clinician, is incredibly important. I think about, you made me reflect on a time when I was at the time living in Ohio, and I was partnering with Columbus City Schools, and I was meeting in the cafeteria with the principal of one of the schools, elementary school. And at the time, even before our meeting got started, there was a young man who was brought in, a little boy who was brought in by his teacher, disciplinary action. And he had done something he wasn't supposed to do. And the first thing that the principal asked wasn't, what did you do wrong this time? Or why are you coming into my office, which was the cafeteria at the time? But she said, well, what do you want to be when you get older? And he said, a doctor. And she said, have you ever, seen a Black doctor? And he said, no. Have you ever seen a Black male doctor? Obviously, the answer was still no. And she said, well, today's your lucky day. I'd like to introduce you to Dr. Gray. And it was just serendipity that happened, but it just spoke volumes to the impact of just being visible, because in this young man's local community, there was no billboard with a Black doctor on it, right? There were no commercials that had Black doctors on it, and probably very few shows that he could watch that had any Black doctors on it. So I think visibility, that's one of the tactics that I think our viewership today can kind of take home with them. I'm gonna throw another log in the fire real quick, and I encourage, as I do that, I want our viewers to again submit questions that you might have. I've seen some come through already, but certainly feel free. We're gonna transition a little bit to our Q&A period, but I want to pitch to you, Ami, and then I'll come to you, Utibe, after this with a call to action. But Ami, can you speak to how Elevance Health has been driving toward this goal of pharmacoequity, and what you're most excited about?
Yeah, no, I think that's a really great question. I am so blessed and so lucky to be a part of a corporation that kind of allows me to focus on one of my passions, which is really the social drivers of health and removing barriers. And I would say, Elevance Health is really, we're driving towards pharmacoequity. Of course, we haven't arrived yet, but we are what we can control, right? We are working in multiple different areas, trying to remove medication disparities based on income, based on race, and primary language. And some of the ways that we're actually doing that is creating programs, creating clinical programs where we can go out there and either be able to question with empathy and with care and social awareness, really asking the poignant questions to give us the true answers to be able to help them. So whether it's, removing a barrier because they don't have access to a PCP, right? Medication is definitely an issue, and that's why we're talking to them, but they don't have access to the PCP. So let's get them access first, right? So they aren't in the ER, they aren't in urgent care, and that prescriber is expected to write the prescription, right? Let's get them the adequate care that they need. Or if they don't have transportation, let's remove the transportation. Or maybe they have a behavioral health condition and they're not even adherent to their behavioral health meds. They don't care about all the other meds, right? Like they're not even worried about it. Or better yet, maybe they don't have somewhere to live that's affordable. Do they really care about their medications if they don't have somewhere to live? We're so focused on the clinical program of medication adherence, but you can't solve any of that unless you look at the patient first and get to the root cause. And those are some of the programs that my team is really creating and trying to, make sure that we're allowing the opportunities and looking for the opportunities, whether it's internally to Elevance or Aunt Bertha or community resources, or really just some of that access. So really, really proud of that, trying to reduce or even remove copays for covered medications, kind of looking at formularies and utilization and things like that, really trying to make sure that our low-income members, our no-income members really have the ability to afford their medication and not just thinking, it's really easy corporately to look at something and say, oh, it's only this much, but every penny counts. Every penny matters. That's what I was taught growing up. The best lesson I can tell you that I learned is one day I got a penny back and my father, and I was like, oh, it's just a penny. And I threw it somewhere. And my father said, you better go pick up that penny because all of those pennies add up to $1 and adds up more, right? And that's the mindset I've kept with me as a healthcare clinician because all those pennies matter. And so for all of us kind of working corporately, when we think about clinical programs or think about initiatives for members, we really have to keep that in the back of our mind. It's every cent counts, every cent matters to the member. And then finally, I would say, one of my most exciting programs that our team has is a longitudinal program. So a case management program where we follow a member throughout their healthcare journey. It's not about that one interaction. It's about that continuum, right? That continuous conversation and part of that journey, because from time to time, things happen, things change in our lives, and that impacts how responsive we are to healthcare. So those are some of the things that, we're really focused on, many more, but that's what I'm really excited about is how do we remove the barriers for our members so that they can really live a healthier life and live the life that they want to live and not be so worried about their healthcare.
And that's one of many reasons that I feel so privileged to work alongside you, Ami. Is truly a pleasure. Utibe, bring us on home before we go to Q&A with our audience. What's your call to action? I mean, you coined the term pharmacoequity, albeit you acknowledge that, these disparities have been around for generations. But from your perspective, what's the call to action for those engaged with us today?
Yeah, so I'll close with the ABCs because I always do love that, and hopefully it makes sense and works. But I think ask is the start, and Ami said it so poignantly in terms of really asking patients about their social needs. Like I think I referenced during our pre-call yesterday that a lot of the conversation around asking about the social determinants was, well, what are we going to do about it? Like, we can't do anything. We're just going to have this in our chart or in the electronic medical record. But without asking, we won't really know what the needs are. And I think that is a segue to become familiar with the resources. Ami mentioned Google is at our fingertips, and whether it is the rebates for our patients, or it's the housing voucher, or even the new policies that are coming down the pike to be able to help our patients afford their medications. For example, through the Inflation Reduction Act, really becoming familiar with those resources and policies that are available to our patients. And the last is C, to just call somebody, call out to a friend, to a partner, to a colleague, to help them to be aware of what's going on with the issues around pharmacoequity. And again, I always suggest calling out to our policymakers to really push them to make this difference happen for our patients. It took a lot of advocacy for our patients to get us to put a cap on insulin prices for Medicare enrollees, for example, through the new acts. And so I think that a lot of those calls are going to have to be made to help ensure equal access to all of our patients.
Perfect. So we have an engaged audience, y'all, and I have two questions I'm going to start with. First, Ami, I'm going to start with you, and let me give you that question real quick, and then I'm going to come to Utibe with a question. The first question, Ami, is, do you believe utilization or practices inherently have a pharmacoequity bias component to them, and how you balance costs with access and pharmacoequity? And while you're thinking about that, the second one, Utibe, I'll come to you. What are some of the recommended articles or books to learn more about health equity? So Ami, I'll go to you first.
No, I think, I don't think it's purposeful if there is a bias, right? I think there's something called unconscious bias that we all kind of have. And so when I think about some of the practices that have probably been built over time, there probably is some unconscious bias behind it. But what I can tell you is that, as where I work and some of my peers and colleagues at other places, there are people that are out there, including myself, kind of looking at how do you balance, how do you make sure that you're creating the right program to make sure that you have pharmacoequity, right? What are you doing to be able to impact the costs, and how are you able to remove some of those barriers for the members? But I think the first thing is awareness, right? Awareness of the topic. And so I think it's a really great question to ask. And I think that awareness is important, having those conversations corporately with our groups and with the different formulary groups, and really making sure that we are making the right clinically informed decisions and not really using personal judgment with that unconscious bias. But I can tell you there is a movement. Gail, our CEO, she talks a lot about health equity and the importance of it. And so it starts top down. If the CEO is talking about it, if it's important to the CEO, it's important to all the leadership under them. And she's made it, one of her main top priorities. And because of that, your question is exactly the things that we look at from a pharmacy perspective and a perspective.
Amen to that. And Utibe,
yeah.
What are some articles or books to learn more about equity?
Yeah, so I just want to echo that was really a great question that was just asked, and appreciate me sharing that perspective. I think as a clinician, I'm always thinking, why these prior auths, like they're getting me down. I'm not able to get these medications to my patients. My Twitter feed is full of people reaching out and saying, yeah, you just posted this cool paper, but I can't get these meds for my patients. So I think us becoming aware as well of what some of the nuanced conversations are happening behind the scenes around utilization management, I really do think, and transparency, really, I think will help both our patients as well as clinicians. I love the book question. I think it's like a plant question. I got to change my Zoom background just so y'all can see that I am obsessed with books. And so this is my usual Zoom background, but things are moving along here. But these are just some of the, I like showing this rather because I don't think it's just the articles or the publications in the scientific media that are going to help move pharmacoequity. I think it's some of this groundbreaking literature that sociologists, reporters, lawyers, non-anthropologists, non-clinical folks are talking about around racism, around health and justice in health. And I think the two that I really have been obsessed with more recently are Heather McGee's The Sum of Us, which really does talk about how whether it's education, it's healthcare, or it's employment, without centering health equity, without a focus on equity, not health specifically, that we're always going to miss out on the next big thing. We're always going to miss out on quality for all if we are not focusing on equity at its core. And the second one, I think Isabel Wilkerson is a really powerful writer. And her recent book, Cast, I think offers just a really unique framework for thinking about justice in our country and the legacy of race and discrimination in our country. And again, I think these stories really help us have a better perspective, a better narrative. We started out with the story with Ami's conversation, and I think that's where all these conversations come back to. It's a story with our patients, the stories with us, with clinicians, and hopefully be able to push the conversation towards pharmacoequity.
And yeah, thank you for sharing. I appreciate the background too. I love some of the books, and I have some of them in my own shelf. Hey, for those who are tuning in and really interested in some of the work that Utibe has done, look, we're putting some links in the chat, and some of you will see that. We'll make sure you have access to some of these links for publications that he has written and put together, and some in partnership with Elevance Health as well. So really excited about that. Please check those out. Look, there are a couple of questions in there here, whether there's, I'm looking at one from a recent PharmD graduate who's going into industry, pharmaceutical biotech industry. I'm looking at a question from someone who's in a pharmaceutical company currently, and both of them are asking, what's the opportunity in partnership with kind of life sciences or pharmaceutical companies in achieving pharmacoequity? What are some things that they can do as they are either active in this industry or about to enter that industry to really foster and advance pharmacoequity?
I think that's a really good question. Of course, I don't have all the answers, but I have some thoughts on it, right? And purely my opinion, but I do think when we have these great drugs that come out, right? I think in research settings, we sometimes think of that demographic, but then once it's to market, that's when we, market it to the big hospital groups and things like that. I think really one of the things that our partners in that industry can do is really look at the pockets of where we have, Utibe, you talked about the sickle cell, right? Are we looking at the pockets of where we see the highest prevalence of sickle cell? And then are we then correlating that to our low income members, or the members that really have little income? Can we go to those areas and really offer that? Not in a research setting, but new to market, and to say, this is something that we want to do. This is a part of who we are. And really kind of going to the different types of communities that really need it, whether it's Hispanic or African-American, Black or Indian or Asian, whatever it is. I think really, again, we try to have this large scale of everything, and then we can't solve anything because we think of everything at such a big scale. But really kind of making it bite-sized and really thinking about, are there 4 or 5 pockets of mayors or governors or state officials or hospitals or schools we can partner with? Can we give it to those who are in need? That's just a thought and opinion.
That's a great start. Thank you, or solution. Thank you, Ami. And I think the conversation around like those communities in need goes back to clinical trials, which we haven't talked about yet today, a little bit outside of our scope as practicing clinicians, but for pharmaceutical companies, the opportunity and hopefully mandate now to ensure that there is representation across these trials for whatever the newest, latest drug is, especially if there are conditions that impact the communities that we've been talking about today, communities who have been traditionally underserved. I think that's going to be huge. I just want to comment a bit on one of the last parts of the question that came up was to try and offer solutions outside of the cost of medications. And I think this is a conversation kind of talking to the Headwinds comment that Darrell made that comes up. So first of all, definitely reach out to us. We want to be in the room helping you all come up with those solutions. We're creating labs, we're creating research teams around this topic. But often it's been said, maybe think about how to not think about costs, like don't address costs. Please give us other solutions outside the cost. Black Americans have about 5% of wealth in this country compared to white Americans. 5%, if you look at and capture the wealth of these individuals in the US. If we continue to try and look for solutions outside of addressing the primary issue, which is that medications are not affordable, we're not going to be able to address this. We can continue to put Band-Aids. We can continue to take patients to barbershops to tell them to encourage them to take their medications, or churches, you name it. But if a medication is $200 a month, and that's more than what I make a week for taking care of myself, my family, my kids, the generations before me who weren't even able to work because of what went down in our country back then, we're not going to be able to fix this. And so I think pharmaceutical companies can vote with their feet if they truly want to address equity and think about how to really think about offering and supported solutions to lower the cost of medications. And that'll just be one of the bigger solutions that they can achieve.
Utibe, look, we could continue this fireside chat for hours, and hopefully we can do this offline with some apple cider, some marshmallows. I'm looking forward to it because there's a lot to unpack, but a lot of opportunity is what you two have highlighted this far. I want to thank you on behalf of Elevance Health and certainly our colleagues at PQA for joining us today for this fireside chat discussion, and to all the attendees who joined to engage with us. There were questions I did not get to, and that just speaks to how engaged people were in this discussion. And so I thank you all for that. At this time, I want to remind you, you're going to get a survey at the end of this, so please fill it out. We want your feedback. But at this time, I'm going to pass to Lauren, and thank you, Lauren.
Absolutely. Thank you, Darrell, and thank you to our panel. It was an incredibly engaging discussion to listen to, as well as obviously our audience has quite a few questions remaining for you. So you've generated quite the buzz about pharmacoequity there. Thank you to Elevance for your support of the webinar today. And thank you to all of our attendees for joining us. Darrell, thanks for the shout out and reminder about the survey at the end of our webinar here. So as you close your webinar, ultimately that survey will pop up. Please complete it to give us some feedback, and have a great day.